This is Radio Health Journal. I'm Reed Pence. This week, will the White House blueprint to cut drug prices really work?
The key drivers of the system, though, are not going to be affected by this without some legislative action. And that's the thing that I think we need to be taking seriously.
Saving money on drugs when Radio Health Journal returns.
I'm Nancy Benson, host of Radio Health Journal. If you enjoy Radio Health Journal, you'll also like our sister show. Here's a preview of what they're covering on Viewpoints this week.
This week on Viewpoints.
The level of creativity and the heart and soul that many of these individuals bring to their work is remarkable.
Urban farming and gardening. Creating jobs for and helping to feed those in need. Then,
an illustrated history of weather from 4.5 billion years ago to today in 100 pages.
These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Viewpoints on your favorite radio station, iTunes and Stitcher.
There are few things that almost all Americans agree about, but one is that the price of prescription drugs is too high. 80% of us agree medications cost too much, according to a Kaiser Family Foundation survey, and it's a problem that affects a remarkably high proportion of pocketbooks. 58% of Americans take at least one prescription drug, and a quarter of us take 4 or more. So the White House, in announcing last month a 50-point blueprint for cutting drug prices, is taking action that few people will disagree with.
My administration is launching the most sweeping action in history to lower the price of prescription drugs for the American people.
We believe that with a free market approach where we have more transparent prices, more competitors in the system, that will bring down the costs overall and will allow it to be a more realistic market than the one we have now.
That's Eric Hargan, Deputy Secretary of the U.S. Department of Health and Human Services, which will be in charge of execution of most of the plan. He says much of the plan can be completed administratively, but there are some parts that will require congressional action. And that's one reason some experts aren't sure that the plan will be as effective as it could be.
There's a lot of ideas in here. Some of them, I think, have the prospect of materially reducing drug spending, probably not in the immediate short run, but in the middle run. The key drivers of the system, though, are not going to be affected by this without some legislative action. And that's the thing that I think we need to be taking seriously and thinking about.
Dr. David Hyman is professor of law at the Georgetown University Law Center and co-author of the new book, Overcharged: Why Americans Pay Too Much for Health Care.
There are some things in the plan that, although individually fairly modest, could collectively add up to a bigger impact over time. I don't think, it'll dramatically bring down prices immediately, and I don't think even its sponsors are suggesting that it will. It's certainly a more comprehensive plan than we've seen come out previously, and it builds on ideas that have been discussed for a while.
Hargan says that one area with real potential savings is to stop what he calls the gamesmanship that keeps generics out of the market. Hyman agrees it's one of several potential promising proposals.
One of them is for the FDA to be much more restrictive in its use of a policy that allows companies to slow generic entry. It's called REMS, and it's basically a sort of drug safety protocol for branded drugs. But if it's used too broadly, it allows the branded companies to slow generic entry. So one of the proposals is we ought to look at that and make sure our processes are not being used in counterproductive way.
Another part of the plan that Hyman believes has promise is a call to move some drugs paid for by Medicare from Part B to Part D.
In Part B, Medicare is purely a price taker. Whatever the pharmaceutical company says is its price is what the Medicare program pays. Whereas in Part D, you have PBMs who are negotiating on behalf of the Medicare program. And so if you move drugs from one program to another, then it will make it possible for there to be lower prices.
That answers one of the major impediments to lower Medicare drug prices, which affect millions of Americans, that the program can't negotiate what it pays. That's true for Part B, but not for drugs moved to Part D. Part D prices are negotiated, not by Medicare itself, but by pharmacy benefit managers working on its behalf. PBMs are often labeled as middlemen, and President Trump says their role is far from all good.
Our plan will end the dishonest double dealing that allows the middleman to pocket rebates and discounts that should be passed on to consumers and patients. The middlemen became very, very rich, right? Whoever those middlemen were, and a lot of people never even figured it out, they're rich. They won't be so rich anymore.
However, Hyman says you still need middlemen, and the plan doesn't regulate the prices they're paid.
Middlemen are never popular in the history of commerce, right? You can sort of look across markets and across time, and nobody likes middlemen. But they serve an important and essential role. In the pharmaceutical market, they structure the market. They get the drugs from the manufacturers through the wholesalers to the pharmaceutical companies, and they administer the insurance benefits. The rhetoric about middlemen was pretty harsh, as it was for the pharmaceutical companies, but we see much more modest attempts to address them in the plan, some study of the issue, and some attempt to make sure that a share of what are called the rebates that are paid by pharmaceutical manufacturers to the middlemen, PBMs, or pharmacy benefit managers, end up flowing through directly and transparently to consumers at the point of purchase.
Those rebates are what Hargan says the government plans to reroute. The plan would also eliminate gag clauses, which prevent your pharmacist from telling customers if paying cash would actually be cheaper than using your insurance and paying the copay. Often, the pharmacy benefit manager pockets the difference.
We look at a system of rebates and discounts that have really been manipulated among many of the different players, because that's how the rules are right now, between pharmacy benefit managers, plans, pharmaceutical companies that swap around payments amongst themselves, and that makes them somewhat insensitive to rising list prices for drugs. It's an artificially high list price because the players who set the list price are not sensitive to the implications of a higher list price. In many cases, they seem to be incentivized to doing it. So we're going to unpick that, remove some of the incentives, and try to make the system more transparent so that at the end we have a set of prices that are closer to reality.
Another effort at transparency could add to what you see in drug ads on TV, according to HHS Secretary Alex Azar in the Rose Garden announcement of the plan.
Think about all the time that everybody spends watching drug company ads on TV and how much information companies are required to put in them. If we want to have a real market for drugs, why not have them disclose their prices in the ads too? Consumers would have much more balanced information, and companies would have a very different set of incentives for setting their prices. We're immediately going to look into having the FDA require this.
I have very modest expectations that that will make a difference, even if, it's fully disclosed and readily apparent. Part of the problem is, the list price of drugs isn't necessarily remotely similar to what most people will pay because most people have insurance coverage. And that's what they focus on, is what's their personal payment, not how much will their insurer be paying. I'm sure there's some public-spirited people that'll pay close attention to it, but for lots of people, it's likely to be kind of like calorie counts that are posted on menus at restaurants. There are a small number of people who pay very close attention to them, and lots of people just skip it.
One other point that Hyman says may have doubtful success is one that the president spent more time on than any other in his policy announcement. He called it global freeloading.
When foreign governments extort unreasonably low prices from U.S. drug makers, Americans have to pay more to subsidize the enormous cost of research and development. In some cases, medicine that costs a few dollars in a foreign country costs hundreds of dollars in America for the same pill, with the same ingredients, in the same package, made in the same plant, and that is unacceptable. You can look at some of the countries. Their medicine is a tiny fraction what the medicine costs in the USA. It's unfair, and it's ridiculous, and it's not going to happen any longer.
The president says he's instructing U.S. trade representatives to deal strongly with other countries, which virtually all regulate drug prices. The reason that their prices are lower than ours. But Hyman says, again, that goes only so far.
The challenge is, first of all, from a political optics perspective, lots of Americans don't understand why we're paying higher drug prices than many other, in fact, all other countries. And so that creates a problem for policymakers. And the freeloading rhetoric comes directly out of that. But just because you force other countries to pay more doesn't mean that we'll pay less. If you want us to pay less, you need to do something within the United States as well.
One way to do that that's not in the plan yet could be very easy and would still involve foreign countries and their cheap drugs. Hyman says we could simply allow Americans to import generic drugs from other countries.
One of the problems that we've seen in the generic market have been price spikes, which we think, have a lot to do with market consolidation and perhaps some problematic antitrust conduct. And so allowing that solves a supply problem. And it's important to recognize, generic drugs are 75-80% of all the drugs that are dispensed in the United States. They're responsible for a much smaller share of spending, but a huge share of the total number of drugs.
However, Hyman says the biggest driver of high drug costs isn't addressed in the White House plan at all, because doing so would fundamentally change how we pay for medical care. We perceive that someone else, our insurer, is footing the bill, not us, and that the bill we get, our copay, is relatively modest. Of course, that ignores the thousands of dollars each of us pays for our insurance bill.
Open-ended insurance is really the driver of high prices. We don't see this in any other consumer market where people are using their own money to buy what they want. But we do see it when insurance is being used. And our recommendations in the book are fairly straightforward. We should buy more things ourselves using our own money. We should reserve insurance for truly catastrophic level expenditures. And on a transitional basis, we should see private contracts used for people basically agreeing that in exchange for lower insurance premiums, they'll restrict the choices that they'll want and demand in the future.
That would return insurance back to what it was a couple of generations ago, when you might have heard it called major medical. It would take care of the enormous expenses of a catastrophic illness or injury, but the smaller expenses of doctor's visits and medications would come out of our own pockets. Those bills can certainly add up, but we'd keep a much sharper eye on what things cost, and it would be much more like how we buy everything else. You can find out much more about all of our guests on our website, radiohealthjournal.net, where you can also find archives of our programs. You'll also find them on iTunes and Stitcher. I'm Reed Pence.
Medical notes this week. Polycystic ovary syndrome affects up to 1 in 5 women, yet the cause has been a mystery. Now researchers think they may have found it, and it may all start before a woman is even born. A study on mice in the journal Nature Medicine finds that when female fetuses are exposed to too much of what's called anti-Mullerian hormone in the womb, it sets up a cascade of events that occur after puberty. Researchers say the hormone triggers brain cells to overproduce testosterone, a hallmark of polycystic ovary syndrome. Researchers were able to reverse PCOS with an IVF hormone-regulating drug. Yet another study carries a strong implication that playing tackle football at a young age is especially dangerous for brain health. The study in the Annals of Neurology finds that people who began tackle football before age 12 experienced cognitive, behavior, and mood symptoms an average of 13 years earlier than those who started playing at age 12 or later. Cognitive and mood problems came about 2.5 years sooner for every year under age 12 a person started to play. And finally, scientists may have finally come up with an antidote for hangovers. Researchers at UCLA say they've developed a combination of 3 enzymes normally found in the liver that cut the blood alcohol level of inebriated mice by 45% in 4 hours compared to mice that didn't receive the enzymes. Scientists say the enzymes could also help prevent alcohol poisoning. Human tests could be as little as a year away. And that's Medical Notes this week. More in a moment.
Thank you for listening to Radio Health Journal, a production of MediaTrax Communications. If you enjoyed this week's show, please leave a review on iTunes or share it with a friend. You can find more Radio Health Journal stories about health, science, and technology on iTunes, Stitcher, and at radiohealthjournal.net.